Absolutely, 1980.
You're senior to me.
Class in 80.
These are only random thoughts. So much of stress upon classroom teaching. I should be telling out, but since there are no students here, when we were students, there was no stress on classroom teaching. Absolutely. The classroom teaching was meant only for first MBBS. And I remember our first impression of medical lecture was by Professor Brahmai Sastri. He was Professor Emeritus in Physiology. That means he was already retired. So if you take it, we joined in 75 and he was taking classes for us. He must have been a student somewhere in 30s. And he was taking physio. He had done a lot of experiments on acetylcholine mechanism. And he used to have an acetylcholine lab for himself. The government had given that much for him in those days. So he used to come and take a class for us. Firstly, his English was beyond us. He was teaching. He was talking in some UK toned English, and there was only epidascope as the teaching method. The book would be open, and that will be coming on to the stage. So the room was darkened. So there were many of my friends who were having transistors and listening to the commentary, India versus England, going on at that time, because there was no TV in those days. But then he used to give a lot of deep insight into the class. But classroom teaching ended there. Anatomy, physiology, biochemistry, the classroom teaching ended there. The moment we jumped onto the clinical side, 90% of the teaching was in the wards. There was absolutely no doubt about it. 90%. We used to have a professor of neurology who was the first DM neurologist of KGH. He had a brilliant checkered history. He did diploma in general medicine. I think those days diploma in general medicine was available in Nagpur. It was one of those diploma in general medicine. I don't think there was any other place where people were getting diploma in general medicine. And then he joined MD general medicine, and I was told that he took a couple of attempts to pass general medicine. Then he didn't settle down. He took a sponsorship, then did his DM neurology. He came to KGH. He was the first neurologist. So his ward of 30 beds. There was no restriction of 30 in those days. There was no MCI, there was no university, there was no UGC. Had all cases of neurology. Anytime anyone could walk in and he would demonstrate a case of choreoathetosis, he would demonstrate some other case, he would demonstrate a case of Parkinson. He was having it in the ward. And he was doing research on zinc metabolism in those days. So most of the teaching used to be in the wards. In fact, we were concentrating very little on the other subjects in part 2. Microbiology, pharmacology, pathology, community medicine, and we were in fact getting punished for not being attentive or not doing well in those subjects. The reason being that all of us were worried. The number of PG seats were very few. Very few PG seats, and we all knew that the majority would be without post-grad. So how to live and survive after MBBS? So classroom teaching was not a concept, very strong concept in 80s. But now the whole thing has shifted. There is so much of concentration only on classroom teaching. There is very little stress on surgical teaching. Surgical teaching, it is MBBS. No? There has to be surgical teaching also, which is supposed to be given during internship. We were all taught venesection. I remember during one of my earliest days in the army, there was a case which was operated, and after the surgery was over, she came and told me, you first see that the venesection is done properly. You catch hold of your mother, you'll have to do the venesection. I was worried about when doing a venesection. If you don't do it, get the venesection properly, that's a big. But we are not teaching, we are not concentrating on surgical skills. Surgical skills is, if you have I had 6 or 8 faculty when I was in HOD, and there was only one person who was capable of sitting down with the student and completing a cataract surgery. It used to take 2 hours. We have a young rookie resident sitting down and trying to do a manual cataract surgery. It will take 2 hours. You require patience for 2 hours. Most people wouldn't be having. They'll be completing their case in 5 minutes and walking away. It takes 2 hours to get it done by somebody. That is something which is missing now. That is the surgical. That's why the simulators are common. Because people don't they don't have time and they don't have the skills also. It takes so much of skills. I got my first cataract surgery on the first day. One thing is I was not knowing how to do it. On day 1 of my post graduation, my guide he was performing. He said, "Come, take the knife." I was lost. I was not interested in ophthalmology, and I didn't know how actually to do. I just gave him a blank look. So he knew that I was I was a wrong person, round in a square. It took some time before I could. Because of course, the surgery was not as advanced as it is now, and the demands of the patients were not as advanced as it is now. But still, for many of you who are here as surgeons who are here, you should develop some skills of imparting surgical training to the residents. That's of utmost importance today. Utmost. I'm over the years now.